Dictation patient Antinori, Antinori, Deborah, Deborah, in quotation Debbie, Dabbe. Please address it Dr. Como, Comeau, initial BNK. Paragraph, date of visit, MAR 20/19, paragraph DGX, osteoporosis. Osteoporosis with T12 vertebral fracture. Stop meds, Prolia, since MAR/17 vitamin D, 4,000 IU per day, calcium, total intake 1,000 mg/day, and naturopathic remedies paragraph, interim history. Dabbe had follow-up BMD in summer of 2018. It showed T-score of -1.6 at the spine and -2.5 at the femoral neck. There has been significant improvement in BMD, particularly at the spine. Stop. She has been doing well and has no side effects to Prolia. Stop. There was no evidence of height loss. Paragraph, impression. Osteoporosis with history of T12 vertebral fracture with a good response to Prolia. Stop. Dabbe is going to continue current therapy and was asked to do blood work. Stop. F/UP APR/20. Stop. Gagliardi, GAGLIARDI, Antonio, ANTONIO. Please address it to Dr. Calvert, CALVERT, initial L, paragraph, date of a visit, MAR 20/19, paragraph, DGX, RA, since 2017, stop. Stop. HTN. Stop. Meds, tadalafil, Tecta, valsartan, Zantac, Dovobet, and telmisartan. Paragraph, allergies, none. Paragraph, previous therapies, MTX, Plaquenil, prednisone, and Remicade. For about a year. Paragraph, interim history. Antonio was referred for blood work, which showed negative RF and anti-CCP, normal CBC, urate and ferritin, creatinine 99, ESR 19, CRP 13. X-rays of both hands and wrists showed osteoarthritic changes, particularly at the CMC joints, with no osteopenia or erosions. Record from his previous rheumatologist showed MRI of the right wrist showed synovitis at the radiocarpal joint with possible erosion. Stop. Ultrasound of the right shoulder showed tendinosis, OA at AC joint, and calcific tendinitis. Paragraph, Antonio remains entirely asymptomatic and he has no evidence of active joints on examination. Paragraph, impression, Tony has OA as well as seronegative inflammatory arthritis that is currently in remission. Stop. We both agreed that he would like to stop off he would like to remain off any therapy for inflammatory arthritis, and I will review him again in fall. Of the shear. Stop. He was asked to contact my office sooner in case of flare-up. Sorry, the letter is on Kennedy, Kennedy, Marilyn, Marilyn, initial P. Thank you for referring Pat, who is 68-year-old female with respect to OA of her both hands paragraph. She is known to have osteoarthritis for a number of years and has been seen by me in the past over 2 years ago. She has been experiencing pain, mostly over PIP and DIP joints of both hands and progressive deformities. She remains on ibuprofen 600 mg BID. She has not been experiencing any joint swelling, but she does have deformities at the DIPs and pain mostly there. At time the pain can be burning. She has no history of psoriasis, IBD or uveitis and no symptoms of dactylitis or enthesitis. She has hypothyroidism, GERD and OSA on CPAP paragraph, meds, ibuprofen 600 mg BID, Synthroid, folate, vitamin B12, andriol, estrogen, prometrium, ASA 81 mg OD, and vitamin D, paragraph, allergies, sulfa, codeine, paragraph, FHX, father OA, paragraph, previously done blood work showed negative RF, and anti-CCP and normal inflammatory markers paragraph, P/E, BP 122/70, no pedal edema, normal heart sounds, lungs clear to auscultation. MSK exams, deformities at DIPs as documented before with telescoping of left second DIP, right second DIP as well as left third and fourth DIPs were tender. There was no evidence of synovitis. X-ray showed previously documented OA changes with no juxtaarticular new bone formation or periarticular osteopenia, paragraph, impression, severe OA. Merlin agreed to try naproxen 375 mg BID. If this is not going to be controlling her pain as effectively as ibuprofen, she will return to it. We also talked about over-the-counter supplements, including glucosamine sulfate and oral Visc. I recommended ketoprofen, 15% cream in Delivra base 3 times a day. She may also consider using splints for her digits and will continue using compression gloves in case her joints will become more stiff or swollen. I can inject them with cortisone. She agreed with this plan. Kucharska, Kucharska, Krystyna, Krystyna. Please address it to Dr. Narouz, Narouz, Lillian, so initial L. Thank you very much for referring Krystyna, who is pleasant 63-year-old female with respect to a possible RA. Paragraph, Krystyna has been diagnosed with inflammatory arthritis. A couple of years ago, she has been experiencing recurrent episodes of intense pain and swelling involving both wrists, shoulder, elbows, and both knees. Usually, during the episode, joints are very swollen, painful, and hot. And this responds well to treatment with anti-inflammatory medications for a couple of days. She has been seen in emergency with this on at least a couple of occasions. She experienced probably at least 3. She's experiencing about 3 to 4 attacks per year. She has no history of psoriasis, IBD, or uveitis, and no symptoms of Raynaud's or Sjogren's. There is also no history of abnormal energy level, fever, chills, weight loss. She had a CT scan of the wrist done in December, which showed mild OA at the radiocarpal and scaphotrapezoid joints with no synovitis. Her blood work indicated RF of 42, normal CBC, creatinine 65, and CRP 1.8. Stop. She has history of hypothyroidism. She also has numbness, mostly in the right hand, digits 1, 2, 3, and she started to wear a splint at night. She's booked for nerve conduction studies in May. Paragraph medications, Synthroid. Paragraph allergies, none. Paragraph FHX, uncontributory. Paragraph she is non-smoker. Paragraph P/E BP 124/17, no pedal edema, no rashes, and no rheumatoid nodules. Normal heart sounds. Lungs cleared. Auscultation MSK exam revealed minor joint line tenderness and stress pain in the right wrist and circular swelling, likely ganglion cyst over the dorsum of left wrist with normal mobility. There was otherwise no tender or swollen joints. Paragraph impression. Christina presents with history of recurrent inflammatory arthritis, quite intense. This responds well to anti-inflammatory medications in a couple of days. I think her history is quite typical for CPPD rather than rheumatoid arthritis. She was referred for ultrasound of both wrists to investigate it further and also relevant blood work. I will review her as soon as all the tests are completed to discuss in more detail diagnosis in treatment. Stop. Thank you for referring this patient for consultation. Schrauben, SCHRAUVWEN, Jeff, JEFF. Please address it to Dr. Salim, SALEEM, initial A. Paragraph Jeff was reviewed, MAR 20/19. Regarding possibility of psoriatic arthritis. Stop. He had an MRI of his right knee, which showed mostly chondromalacia, patella in 3 compartments, branching tear of posterior horn of medial meniscus, suspicion of partial thickness tear of MCL, and small joint effusion with large Baker cyst with no clear evidence of active synovitis. Stop. He received cortisone injection to his right knee with no significant improvement. Stop. As you recall, on physical exam, he had no evidence of synovitis, dactylitis, or enthesitis. Paragraph. Blood work showed CRP of 3.9, negative RF, and HLA B27. Paragraph impression. I discussed with Jeff results of all of his investigations. At the present time, he has no evidence of psoriatic arthritis. Stop. He will follow with orthopedic surgeon regarding OA of his right knee. I'll be happy to reassess him in the future if any problems arise. Zwart, ZWART, Liesbeth, Liesbeth. Please address it to Dr. Sterling, STIRLING, initial D, and CC Dr. Mian, MIAN. Initial Z. Thank you very much for referring Lisbeth, who is 46-year-old female, regarding possibility of psoriatic arthritis. Stop. She has psoriasis for over 4.5 years, and it's mostly restricted to her hands and feet. She has no scalp or nail involvement. She also has no history of IBD or uveitis. Stop. She has history of plantar fasciitis in 2004, which improved with with wearing orthotics. Stop. She was seeing you for nerve conduction studies due to burning pain and the dorsum of right hand. This, she believes, is related to position at the keyboard at work. She has never experienced any joint swelling, and she has no joint stiffness. She also has no symptoms suggestive of dactylitis or enthesitis. Paragraph meds, none. Paragraph allergies, none. Paragraph other medical history, atrial fibrillation / flutter, right-sided conductive hearing loss, lichen planus, and angiomyolipoma, right kidney. Paragraph, she is lifelong non-smoker and does not drink alcohol. Paragraph, FHX, uncontributory. Paragraph, P/E showed psoriatic patches over both hands, mostly overlying MCP joints. No nail involvement, normal heart sounds, lungs clear to auscultation. MSK exam revealed no evidence of either tender or swollen joints and no evidence of dactylitis or enthesitis. Paragraph impression. Elizabeth has psoriasis, but at the present time she has no evidence of active synovitis, dactylitis or enthesitis to suspect psoriatic arthritis. I do not think that at this point any additional investigations are necessary, and her x-ray of hands and wrists was reported as normal. Stop. I informed her that there is 1 to 2% risk of developing psoriatic arthritis per year in patients who have psoriasis. Stop. I will be happy to see her again in the future if any problems arise. DICICCIO, DICICCIO, Maureen, MAUREEN. Please address it to Dr. Krishnar, KRISHNAR. Paragraph, date of visit, MAR20/19, paragraph DGX, stop. Stop. Meds, MTX, 20 mg POOW, folate, 10 mg POOW, Symphony, IV, 150 mg Q8 WKS, Percocet, gabapentin, Zenhale, Prozac, Oxazepam, Epival, Tylenol, Advir, and Omnaris. Paragraph allergies, Clav, erythromycin. Paragraph interim history. Maureen started Symphony in December of last year, and she has been doing well. However, recently was diagnosed with pneumonia and treated with antibiotics. She recovered quite well. Her last infusion was in January. Stop. And her last blood work showed CRP 1.9, ALT 10, normal CBC, ESR 21, ALT less than 10. Paragraph. Currently, she's experiencing less than 15 minutes of morning stiffness. P/E shows evidence of residual synovitis in the left wrist and both ankles. No change in damage. Stop. No tender joints. Paragraph. CDAI 4, 5, 6, CDI 7. Paragraph impression. RA. Maureen already started to respond to Simponi, and she will continue current treatment along with methotrexate. Stop. She was given requisition to continue blood work every 8 weeks. Paragraph F/UP/JUL/19. Patient WAG, WAGG, Linda, LINDA. Please address Dr. Powers, POWERS, initial B. Thank you very much for referring Linda, who is 75-year-old female with respect to possible inflammatory arthritis. Paragraph, Linda is known to have history of OA, and she also developed some swelling in the right hand in August of last year and subsequently left wrist in November. She was diagnosed with carpal tunnel syndrome by nerve conduction studies indicated moderately severe CTS on the left and slightly less so on the right. She already had a surgery on the left carpal tunnel by Dr. Assad, ASSAD. She has been experiencing ongoing stiffness in both hands as well as swelling throughout the MCP and PIP joints. She is losing her dexterity. Remaining joints are not painful or swollen. She has history of hypothyroidism, which is treated and is otherwise quite well. She has no history of fever, chills, weight loss, lymphadenopathy, and no symptoms suggestive of either Raynaud's or Sjogren's. She also has no history of malabsorption, type 2 diabetes, or vitamin B12 deficiency. Paragraph, current medications, diclofenac 50 mg BID, in brackets Wasson Celebrex, which seem to work better for her, close the brackets, levothyroxine. Paragraph, allergies, none. Paragraph, FHX, uncontributory. She's non-smoker. Paragraph, P/E, no rashes, no rheumatoid nodules, normal heart sounds, lungs cleared, auscultation, MSK exam revealed synovitis over both second and third MCPs and possibly right third and left second, third and fourth PIPs. She also had very tender flexor tendons, right second to fourth and second and third on the left. She was not able to make a good strong fist. Paragraph, blood work, negative RF, ESR 11, CRP 5.1, ferritin 139, normal CBC, negative ANA. Paragraph, impression, Linda has bilateral carpal tunnel syndrome, operated already on the left. She also has evidence of inflammatory arthritis that needs further investigations. She was referred for PDUS on hands, wrists, and carpal tunnels, as well as relevant blood work, and we'll try to arrange it for her as soon as possible, and I will contact her regarding further therapy after those tests are completed. She agreed with this plan. And Anderson, ANDERSON, Stafford, STAFFORD, Heidi, HEIDI. Please address it to Dr. Galloway, GALLOWAY, initial V. Address it, send a CC to Dr. Galloway and address to Dr. Elmazarki, ELMAZARIKY, initial N. Paragraph, thank you for referring Heidi, who is 48-year-old female, regarding possibility of psoriatic arthritis. She has psoriasis since teenage years and was diagnosed by my colleague rheumatologist in 2017 with psoriatic arthritis. Her psoriasis currently is not active. She also has history of pulmonary embolism following left knee arthroscopy. She is known to have OA and meniscal tears and had several arthroscopic procedures on both knees. She also has history of fibromyalgia. Paragraph, for her psoriatic arthritis, she was treated with Areva. as well as prednisone up to 25 milligrams per day. Prednisone caused elevated high blood pressure and insomnia and Arava flu-like symptoms, and both were stopped. She also had methotrexate therapy for several weeks, which was discontinued due to GI intolerance. She does not recall being treated with any other medications. Paragraph. At the present time, she's experiencing a pain in her hands, wrists, and feet across MTP joints. She has no history suggestive of dactylitis. She possibly had Achilles enthesitis in the past. She has also widespread generalized pain and is stiff throughout the entire day. Paragraph. She is non-smoker. She also has history of possible anxiety. She also has she has history of anxiety. Paragraph. Meds: Xarelto 20 mg OD, Adderall 20 mg OD, Gravolet HS. Paragraph. Allergies: sulfa, penicillin, tetracycline, and possibly macrolides. Paragraph. FHX, no history of PSA. Paragraph. She is lifelong non-smoker. Paragraph. P/E showed no evidence of psoriasis, and normal general physical exam, MSK exam, revealed multiple tender joints, including both shoulders, both wrists, and MTPs. She was also tender in all fibromyalgia tender points. Synovitis was seen at the left wrist, both second and third MCPs, left third PIP and right third PIP and left third and fourth PIP. In total, she had evidence of 8 swollen joints. There was no evidence of dactylitis. She was tender at several antesial points. Paragraph. Impression: evidence of psoriatic arthritis as well as fibromyalgia. Heidi was referred for blood work as well as x-rays of hands, wrists, and feet, and power Doppler ultrasound. I discussed with her various therapeutic options. She would like to try Otezla as the safest one of the Otezla, since she is concerned about the safety of other agents, especially TNF-alpha blockers. Since she has private insurance, I will apply for Otezla coverage. I discussed with Heidi potential side effects, including GI intolerance, as well as a risk of depression and potentially suicide. She does have a remote history of depression, which was called in brackets reactive, and she experienced that around her separation, slight divorce from the first husband. She agreed with this plan. Anna Jaroszyńska.